Hi, I'm Alison Newman and I work at the University of Washington Alcohol and Drug Abuse Institute. I provide training and technical assistance on overdose response and opioids.
And I'm Meg Brunner and I'm a research librarian at the UW Alcohol and Drug Abuse Institute.
Today, we're going to talk about a few things, including what are opioids, what is opioid use disorder, how can library staff engage with people with opioid use disorder, what are libraries in other places doing, what are resources library staff can share. So to start a little bit, opioids, that's what we're going to be talking about today. There are naturally derived versions, which are generally when we talk about opiates, and as well as opioids include also synthetic versions. Opioids are a class of drugs that work on the body's endorphin system. It's one of the systems that manages pain and pleasure in the body. If you turn your ankle, it will hurt badly for a minute or two, but then your endorphin system comes in and manages that pain. The endorphin system is also that rush you get from riding a roller coaster or when you see someone you like. Endorphin actually means inner morphine. Opioids are chemically very similar to your own endorphins, but they have a much stronger effect. There are prescribed opioids like oxycodone, hydromorphone, and many others that are used to treat pain. There are also illicit opioids like heroin and the classic opium, which is the opium poppy that you see here. Fentanyl has both prescribed versions that are used for pain or as an anesthetic, as well as illicit forms that show up in heroin or in counterfeit pressed pills. So there are a bunch of reasons that people have for using opioids. These can include treating physical pain. People can also take opioids to reduce mental pain or to cope with emotional trauma or a challenging living situation, like sleeping in a tent. Many people who use opioids are using them because they have opioid use disorder. They may also use them for all of these reasons. So what is opioid use disorder? It's a chronic medical condition that is more than just physical dependence on opioids. People who have opioid use disorder also have psychological and social issues related to their use. This can be intense craving for opioids and putting their use ahead of their relationships or work. I'm physically dependent on caffeine, but it doesn't affect my relationships with friends or family, so it doesn't qualify as a use disorder. Some people, when they try heroin or other opioids, may feel really good the first time they use it, as you can see on this chart. So with new use, people will feel really good. If they keep using opioids, over time they'll have increased tolerance, meaning they will need more to have the same effect. They will also start to feel symptoms of withdrawal when they don't use. These symptoms include fever, chills, nausea, diarrhea, emotional distress. I've heard withdrawal described as having the feeling when you've hit your funny bone and your girlfriend broke up with you on the same day. So it's this mix of physical symptoms and emotional distress. People with opioid use disorder continue to use opioids to avoid withdrawal. We're learning more and more that opioid use disorder is best treated with medications that can help people get out of the cycle of craving, use, and withdrawal. The medications we're talking about are buprenorphine, also known as Suboxone, methadone, and naltrexone. The first two are opioids that help people avoid symptoms of withdrawal, and the third is a full opioid blocker, so people can't feel the effects of opioids. So what you'll see in this chart is with new use, people feel really good. Over time, they need opioids to just not feel really bad, and that medications can help them balance out. So, when we're talking about why do people develop opioid use disorder, there are a few different things. I'm a public health person, so I like to look at things from a population level. This diagram is called the epidemiologic triangle, and it's used to explain how diseases spread, usually for communicable diseases like malaria or flu. With opioid use disorder, we have an agent of disease, which is opioids. You can't develop opioid use disorder if you've never used opioids. Then you have a susceptible host, which means someone who can develop the condition. Not everyone who tries opioids develops a disorder, but we know that some people are more likely to develop one. Genetics, personality, life history, trauma, and social setting all influence the likelihood that someone who tries opioids will develop opioid use disorder. The last piece is the environment. We had an environment where there was a big increase in the availability of prescribed opioids in the U.S., and people were prescribed these medications or tried them from friends and family. As we reduced prescribing, people switched to heroin, which was also easy to get. So you can see there are really several ways we can work on this issue. One is to help make people less susceptible to opioid use disorder. The other is to make an environment where not so many people try them in the first place. So when we're talking about opioid use disorder, I like this bathtub because it shows that even if we turn off the tap of new diagnoses of opioid use disorder, we will probably still have a lot of people who have the condition, because the only ways out of the bathtub are really through long-term recovery or death. Fortunately, long-term recovery is possible, but we will still have a large population with opioid use disorder for a long time. So what does this look like in terms of data? This is national data from the CDC. You can see we had a big increase in deaths from prescription opioids starting in the late 1990s, which shifted to a rise in heroin deaths around 2010. In 2013, deaths from synthetic opioids like fentanyl started to rise. The illicit drug supply has been increasingly cut with fentanyl, and people may not know they're using it. Fentanyl is very potent, and when it's cut into drugs, it can be like chocolate chips in a cookie and not always evenly distributed. This means that at any time, someone who uses won't know how strong the drug is, and they have a higher risk of overdosing. You can see that Washington's overdose data looks a little different. We're in the middle of the pack as far as overdose deaths go compared with other states, and we haven't yet seen that hockey stick rise in deaths from fentanyl. Our heroin is more likely to be black tar, which is harder to put powder into. In the East and Midwest and in Vancouver, BC, they're more likely to have powdered heroin. In Washington, where we've seen fentanyl is in counterfeit pressed pills or in powders. King County has also had an increase in overdose deaths, with the majority related to opioids. However, stimulants are increasingly involved in overdose deaths in the county, with a big increase in deaths from methamphetamine. So this slide shows all the overdose deaths, and you can see there's an increase from 2008, where there are 270 overdose deaths, to 2018, where there are 414. This slide includes all the substances involved in all the overdose deaths, so one individual may be counted more than once. You can see that although we have had a big increase in heroin and fentanyl deaths, methamphetamine deaths have risen even higher. So the majority of people who died from overdose in King County in 2018 were housed. 16% were homeless. Homeless people are about 1% of the overall population of the county, so they still have a higher rate of overdose deaths than the rest of the population. However, it's important to note that overdose deaths are happening in people who are housed, and it's not just a problem for people living outside. And this data, all the King County data, is from the King County overdose dashboard, which you can find below. So the majority of people who died from overdose were male. The age was fairly widely distributed across, under 30 to 60 plus, with no one part taking up the majority. So it's not just older people or younger people, it's really happening across the spectrum. Most of the people who died from overdose in King County were white. However, American Indians may be undercounted, and African Americans are slightly overrepresented based on their population. As you can see, overdose deaths happen throughout the county, with about half happening in Seattle, a third in South King County, and the rest spread out throughout the county. So here at the Alcohol and Drug Abuse Institute, we help do a survey every year of people at syringe exchange programs. The last survey was in 2017, and we surveyed 1,047 people at exchanges throughout the state, with 427 in King County. About 2/3 used heroin as their main drug, and among those, 78% were somewhat or very interested in reducing or stopping their opioid use. What this means is that people aren't using just for fun or enjoyment, it's really about avoiding withdrawal, and most people would like to be using or using less.
Okay, so I'm just going to jump in for a couple of slides here to talk to you a little bit about what other libraries around the country have been doing to try to help with the opioid crisis. I'll start with just a quick overview of some of what's being tried, and then move into telling you some stories about specific libraries around the U.S. So first and foremost, the simplest thing. Libraries are working to be better prepared to provide basic resources for information and referral to patrons who ask about opioids. Several library websites I looked at offered recommending reading lists about opioids, and we prepared a few handouts that had local resources, national resources for statistics and health information, and also a list of books and movies that you can read yourself or recommend to patrons, and we'll talk a little bit more about those later. Next up, libraries have been branching out from providing resources on demand to more proactively providing them by doing community education programs. I'll talk a little bit more about this on the next slides as well, but several libraries in Washington and elsewhere have been hosting programming about opioids, including panels of experts to talk about various aspects of the crisis, events for National Overdose Awareness Day, which is in August, and even hosting naloxone training for the public, which the library system in Everett, Washington has done. After that, offering basic training for staff, just like this webinar you're watching right now. And then there's emergency planning, and I really like this idea, and a lot of the librarians we've talked to so far did as well. Some libraries have started to host overdose drills with their staff, where they review everything that needs to be done in case of a suspected overdose in the library. Who calls 911, who moves patrons away, who goes outside to wait for the ambulance, etc. This can really help make staff feel more prepared and less anxious about encountering an overdose, and also make sure that everything goes really smoothly if they ever do. It's really easy to implement, and it makes a big difference for everyone. Up next, Libraries have also been partnering with local community, advocacy, or public health organizations to bring training in for staff or the public, or to do things like set up an information table once a month in the library where patrons can come and get information and ask questions. This is a pretty low barrier thing to do as well, and it's something that can be really helpful. Next, and now we're getting into slightly higher barrier stuff, actual naloxone training for staff. This is something that has started to finally gain some real traction in the library world, but it's still somewhat intimidating for library administrators and also some library staff as well. There's also a cost barrier, though all public libraries in the U.S. can now request and receive 2 free nasal spray naloxone kits from the manufacturer Emergent Biosystems. Next up, libraries have increasingly started hiring actual social workers as part of their staff, and I'll talk a little bit more about this on the next slide as well. Some smaller library systems that couldn't afford to pay for an actual staff member have also started volunteer programs or even partnered with a local university to get social work students involved in volunteering or doing school projects in the library system. And then finally, hiring peer support specialists to go with the social workers. I've only read about one library system that has integrated peer specialists, but peer support specialist is a vocation that's definitely growing right now. These are usually folks in recovery who are trained to help others seeking their pathway to recovery. They can help with providing information about different treatment options and community resources, and also offer the added benefit of lived experience they can share for support as well. So that's just a quick overview to give you some ideas for things you might think about trying out. Now just a few stories about specific libraries who have been doing some cool things. The first story I'll tell you about is McPherson Library in Philadelphia, which has been in the news a lot in the last couple of years because they were one of the first libraries in the country to begin offering naloxone. The building sits on the edge of a large park, McPherson Park, where a lot of locals and increasingly a lot of out-of-towners go to use heroin. So many so, in fact, that the locals refer to it as Needle Park. Staff had seen many people overdosing, both in the park and inside the library, often in the restroom, and one day had even had to make 5 911 calls alone. The first thing they tried to help with the issue was instituting what they called a bathroom monitor. Adults were asked to leave a library card or other piece of ID at the front desk, and a security guard would time them and knock on the door after 3 to 5 minutes. Understandably, this didn't go over well with a lot of patrons. They also began having those overdose drills I described earlier, which really helped staff feel more confident in their ability to help patrons who were overdosing. All of this helped for a while, but then heroin and opioids in their community exploded. With incidents on the rise, a group of McPherson staff started asking for naloxone training, signing up for a voluntary training class with Prevention Point Philadelphia. Prevention Point also supplies them with naloxone kits, so this is a great example of a library partnering with a community organization. Since then, the library staff have administered naloxone dozens of times. One article about them reported that they've done it so often, they can now tell what type of substance a person is likely to have overdosed on by the sound coming from the restroom. Heroin victims slide sluggishly into unconsciousness, the library staff reported, while victims of fentanyl collapse instantly with a thud that resonates throughout the entire building. The program has been so successful at keeping overdosing patrons alive that the library system is now considering spreading it to the other branches as well. The other big library you'll see in the news a lot in regards to naloxone and opioids is the Denver Public Library, which was one of the first libraries in the nation to offer social workers as part of their normal library staff. Several years ago, I got to take a tour of the library and meet the first social worker they hired onto their staff. That was the first time I'd heard of a program like that. She said she mostly spends the day walking around the library talking to people, finding out whether they had any information or social service needs, talking to them about treatment options for mental or physical health issues, and just generally being a resource for community support. In 2017, the downtown branch had a heartbreaking and traumatic experience for staff. A young homeless man overdosed and died in the library. The response from the administration was fast, so by then they had hired a second social worker, and that woman immediately ordered 12 naloxone kits, thinking that would be plenty to last them for a while. When they used just 4 in 6 days, though, they knew they had to do more. They now have over 350 staff trained to administer naloxone. That's over half their staff. And librarians at the downtown branch reversed about 13 overdoses in 2017 and spent about $1,800 on naloxone kits. And then a couple of Washington stories. Everett Public Library System had an opioid outreach specialist from Snohomish County deliver naloxone training to the library staff last year. I think this is the first library in Washington state to do this. And they've also made some changes to their restrooms, like using shorter stall heights to make them less inviting to hang out in, and adding sharps containers to collect needles. After the success of their staff naloxone training, the library also had the trainer come back for a second round, this time for the public. Almost 60 people from the community came for that event, which really shows the level of interest from folks in that type of programming. When questioned about whether she was concerned that the sharps containers and naloxone training would actively encourage more people to use drugs at the library, the Everett Library Director said, "Not really, because people are going to use where they want to use, and I haven't seen any increase. I just feel like we have the tools to handle it now. But I wouldn't say that it's a worry that they're going to rush here as a safe place to inject. Obviously, I want my families who are coming in here with children to feel safe and welcomed and feel they can use the library services. But that doesn't mean I can't allow access for people that might have drug addiction issues or don't have homes. So I need to provide that balanced spectrum." And then finally, Multnomah County in Oregon, which is Portland and the surrounding areas, will be rolling out a naloxone program in their library system this summer at 5 locations. And they're mostly focusing on rural branches for this. Initially, most of the overdoses they were seeing were in the downtown branch in Portland, where emergency response is pretty fast. But they've been seeing an increase in rural branches in the county over the last few years, and because emergency response can be a lot slower in these regions, those branches felt like the right places to start rolling out this program. Makes sense. And then, of course, King County Library System has hosted several events for International Overdose Awareness Day, which is great. The events included prevention training, information about safe disposal of medications, and even some free naloxone. So what can library staff do to help people who have opioid use disorder? Much of what you already do, like offer a safe space and compassion. You can also provide resources and education for the broader community on this topic. You can also use neutral, non-judgmental language. I say opioid use disorder rather than addiction because it's more medical and less loaded than addict. I also don't say drug habit because that minimizes the condition, and opioid abuse ignores the fact that people are using because it's a medical condition. I also try to avoid addict, junkie, or abuser and say someone with OUD. Rather than saying someone is clean, it's less stigmatizing to say someone is in recovery, not using, or in remission. Saying someone is clean implies that someone who is using is dirty. I talk about medications for opioid use disorder rather than replacement therapy, since that suggests that someone is just replacing heroin with the medication. We wouldn't call insulin replacement therapy, so we shouldn't for OUD either. Keep in mind that people can talk about themselves however they like, but we as professionals should use neutral language. Most library staff already know how to tell if something is coming from a valid source, but that doesn't always tell you if what you're looking at is something worth recommending. For example, you might pull up some newspaper articles for a member of the general public to read, thinking those would be pretty accessible sources of information and pretty valid too. But while a lot of newspaper articles may contain accurate information, they may not be presenting all the valid information, and they could even be presenting information in a harmful way. So we came up with a few questions to ask yourself as you're evaluating a resource beyond the traditional ones you're already aware of. Does it use neutral, non-stigmatizing language? If it's about treatment, does it discuss medications for OUD? And is it clear that medication is an effective treatment for most people with OUD? And does it describe OUD as treatable and chronic?
So when we have done this presentation at KCLS Libraries in person, we've talked a lot about sharps and safety, since this is a concern for some library staff. We've heard that staff sometimes encounter sharps in people's bags or in the bathroom, so we wanted to provide a little bit of information about safe sharps disposal. Most of this information is pulled from the Seattle Public Utility, which has excellent tips for safe sharps disposal, including: do not pick sharps up with your bare hands, use a glove or tongs, shovel, or a broom or dustpan. Place used sharps and syringes in a manufactured sharps container, such as one you purchase at a pharmacy, or a 2-liter plastic soda pop bottle. Make sure the lid fits tightly and tape it shut. If you use a plastic pop bottle, label it "Sharps Do Not Recycle." And then if you want to learn a little bit more, there's a nice video from the Seattle Public Utility on sharps collection. Other tips are: do not break the needle off from the syringe, and do not put sharps in the garbage. And you can learn a little bit more about these tips from the Seattle Public Utility. They have a lot of information on sharps collection, as well as where people can dispose of their own personal sharps. So for this section, we're going to talk about overdose response, where you can find training and resources related to that. As Meg mentioned, some libraries in the country have started to have naloxone on site in case of an overdose. This video here describes the signs and symptoms of an opioid overdose and how to respond and use naloxone, the overdose antidote. The video is also available in Spanish, and both versions are also available with closed captions. And you can find all of those on our website, stopoverdose.org. So what is an overdose? It's more opioids than the body can handle. In an overdose, someone's brain is so relaxed it's not remembering to breathe. Opioid overdose is different than a heart attack. It's really a respiratory emergency. So the signs are related to that. They are usually slow or no breathing, blue skin, lips, or fingernails, and that the person can't be woken up. If someone can talk to you or look you in the eye, they're not overdosing at that point. So what is naloxone? Naloxone is the antidote to opioid overdose. It blocks the receptor in the brain for opioids and puts someone into withdrawal in a few minutes. Naloxone is very safe to use. For someone who hasn't used opioids, it has no effect at all and is the same as administering saline. I actually was training someone on how to use the Evzio, the auto injector that you see here, and it comes with a trainer and 2 kits. I thought I had the trainer. I opened it up and listened to the robot instructions. I put it in my leg and realized I had given myself a dose of naloxone. Because I was not using opioids, it really had no effect except the embarrassment of having accidentally given myself naloxone. I waited the 30 to 90 minutes that naloxone has an effect and really felt nothing. So you really don't have to be concerned about using naloxone on someone. You can't harm someone with naloxone. You can really only help them. So naloxone currently comes in 4 different forms and they all work equally well. The most common form that organizations and law enforcement has been using in case of an overdose is the Narcan nasal spray. Syringe exchange programs in the state mostly distribute the injectable naloxone. Another thing to know about naloxone is it doesn't encourage someone to use more drugs, and once again that it's very safe to use. The only thing you can do with naloxone is reverse an opioid overdose. So just an overview of what to look for and what to do for an overdose. In an overdose, first check for signs and symptoms. So things to look for are not breathing or very slow breathing. It can sound like a heavy gurgling snore even. So if you hear that and someone's not breathing well, that can be a sign. Also, if you can't wake them up, that's really a strong indicator there's something wrong. Other things to look for are cold, clammy skin or blue skin. So you want to try to wake them up. We say, try saying their name, try a sternal rub, which is knuckles on sternum, or if that's hard to reach, we say an ear pinch. We know that library staff aren't supposed to touch someone, so if someone is in a chair, you could try kicking the back of the chair. That's one thing library staff shared with us. And we do know if you can't wake them up, you want to call 911. It's really important to call 911 for an overdose, even if you have naloxone. After you've called 911, you then want to administer the first dose of naloxone. With the nasal spray, you just put it up the nose and press the plunger. The person doesn't have to be breathing for it to be absorbed. Then, if it's safe for you to do so, you want to start rescue breathing. Overdose is usually a respiratory emergency, so it's very important to get oxygen to someone's brain. If someone's heart is not beating, you can use the AED and then do chest compressions. If someone's heart is beating, we really think it's important to do rescue breathing. If the person hasn't woken up in 2 to 3 minutes, you would administer the second dose of naloxone. And you can use the same nostril, you can use a different nostril, it doesn't really matter. When someone wakes up, they may be in mild to moderate withdrawal. So they'll be feeling those symptoms we talked about earlier, like nausea, chills, emotional distress. You want to let them know what's happened and that they should feel better when the naloxone wears off in 30 to 90 minutes. Also, let them know they shouldn't use opioids again during that time since the opioids won't have an effect and can increase their risk of overdosing when it wears off. Encourage them to go with medical help since overdose can start again. And we know that as of this recording, King County Library System does not have naloxone, but this is just information for you to have, partly so that you understand what overdose looks like and what an appropriate response is, and then also if you are concerned about yourself or someone else in your life, this is good information for you to have. You do want to stay with them until help arrives and really encourage them to get medical help. It can be, although naloxone can reverse an overdose, there can be other medical issues. So in Washington, we have laws that provide protections for people who carry naloxone and use it for an overdose. Anyone in Washington who is at risk for having or witnessing an overdose can carry and use naloxone and is provided protection under our Washington laws. Another law provides protections for organizations that distribute or have naloxone on site in case of an overdose. In addition, our Good Samaritan laws provide protection for prosecution for possession for a victim of an overdose and the person who calls 911. These laws, however, do not provide protections for outstanding warrants or felonies, so it's just something to be aware of. These laws are really meant to encourage people to have naloxone, to use it, and to call 911 for an overdose. So, the most important thing to me is that library staff know what an overdose looks like and to call 911 if they suspect an overdose. So it's really, if someone can't be woken up, we know that some sort of serious medical emergency and you should be calling 911. The other thing is that you can do now is know how to help someone find naloxone, the overdose antidote. We have a webpage on stopoverdose.org that has a map of locations where someone can find naloxone. This list includes the syringe exchange programs in the state where someone can go and get naloxone for free. It also includes all the pharmacies where someone can walk in and have a pharmacist hand them naloxone and charge their insurance. In Washington, Medicaid pays for naloxone with no copay. So this is an example of our map. You can just type in a zip code and find locations near you where naloxone is available without seeing a doctor first. Some other things you can do are to talk to someone about overdose if you're comfortable. So you can discuss ways that they can reduce their risk of overdose, such as not using alone, because if someone uses alone and they overdose, someone will not be around to call 911. You can also talk to them about using more slowly. We have tips for that on stopoverdose.org that you can check out. If you do talk to someone about naloxone, help them make a plan about where it's stored and make sure they let other people know they have it. You can't use naloxone on yourself once you've overdosed, so it's really important that people have a safety plan. The other thing you can do is if someone has expressed an interest in treatment, you can share the Washington Recovery Helpline webpage with them. They have a wonderful new locator map where someone can find treatment options that work for them. And what I really like about this is it's not just the zip code. People can also say what kind of medications they're interested in, what sort of population they are, how quickly they would like to access treatment, and what setting they would like to access treatment in. So this is a really wonderful resource that we really want everyone to be aware of, because if you feel like you need help or you have a patron or friend or family member who needs help, this is a really great way to help find that. So we have a few other resources, some of that we've mentioned. One is our online overdose training video, which is only 8 minutes, and as I said, is available in English and Spanish. We also have the same information in a brochure, also available in English and Spanish. A little handout, Naloxone is Closer Than You Think, with steps about how to find and access naloxone, and Good Samaritan law resources, including a little card as well as posters to help people be aware of the protections of the Good Samaritan law and know that they should call 911 for an overdose. And as I said before, the Washington Recovery Helpline is a really wonderful resource for people looking for help for substance abuse, problem gambling, or mental health. And they do have the online locator map, they have a chat feature, as well as their phone number.
We also made a couple of handouts that will be made available with the webinar. The first is a list of resources for your own education or to help educate others, and the second is a list of books and movies that are about opioid use. Not all of them are perfect, but they can help put a human face on opioid use. We also put together a playlist of music about opioids that can be used as an empathy tool. You can find it if you go to Spotify and search for KCLS Opioids playlist.
And I just want to say thank you so much to Melissa Munn for setting up this training series. We've really appreciated working with library staff and hearing about everything that you do and the wonderful work you do in our communities. And really thank you for the opportunity to provide this education and partner with KCLS on this series.
Please reach out to us if you have any questions.